All right. Hello, everybody, all my movers and shakers here. Welcome to the community table. Today, our topic is supporting older adults who are experiencing homelessness. And we've got Caitlin Sinovec from the National Healthcare for the Homeless Council, who's going to talk to us, and they always do a good job with our training. So I know Caitlin is new to us, but I have no doubt that she's going to do a good job for us. So I'm not going to waste any more of her time. I will turn it over to her. And if you have questions or comments, you can put them in the chat or raise your hand, and we'll either read your comment or maybe unmute you if needed.
Great.
All right, Caitlin, it's all yours.
Sounds good. Yeah. Thank you so much, Laura. And welcome everybody. And I think we have built in a good amount of time for questions today. So if you want to throw them in the chat while I'm presenting, and then if there's certain pauses, I'll take a look at those and we'll be able to see what questions so we can kind of answer them throughout. And then we'll definitely have time at the end as well. Um, So, as noted, I'm from the National Healthcare for the Homeless Council. I just want to acknowledge my colleague Devora Keller, who also helped put these slides together, but is not here presenting today. But I'm here to talk with you about older adults experiencing homelessness. You are likely familiar with us at the council. I know you've had a few of our presenters before. So, just a reminder of our mission. Our goal is really to build an equitable, high quality healthcare system through training, research, and advocacy in the movement to end homelessness. And we're made up of a lot of members of our community who are providing direct services in health centers, medical respite care shelter programs, and our National Consumer Advisory Board. So we're going to dive into the topic today. So I'm going to start sort of high level, and then we're going to think about the experience of older adults experiencing homelessness from a couple of different perspectives around their medical needs and around their social needs. So regardless of the setting that you're working in and working out of, there will be hopefully some helpful information or just, some things that you're probably seeing in practice, and then some things to consider in care. So you all are relatively familiar with what homelessness is, right? This is what you're doing every single day. I like to include this slide just to help us remember, the services around what HUD identifies as people experiencing homelessness, right? Folks who are staying in shelters, vehicles, sleeping outside, abandoned buildings, etc. And then that's a little bit different than our definition of homelessness from Health and Human Services, which is our funder for healthcare for the homeless programs and health services programs. And so programs that are funded by HHS might have a little bit of a bigger reach or volume of folks that they see. But when we're thinking about older adults specifically, it's important to think a lot about those who are at risk of homelessness and exiting treatment and incarceration. So exiting treatment is not specifically just folks who are exiting substance use treatment, but it could be people who are exiting treatment, such as inpatient rehab, skilled nursing care, right? Some of those short-term cares. And a lot of folks, as we'll talk about in a moment, begin their journey of homelessness as an older adult after an acute medical event. So thinking about these different definitions and populations and thinking about how we can prepare programs and services to be able to do that. There are also older adults who do exit incarceration who maybe have lived out a prison sentence of 20 years that happened when they were a younger adult who may be exiting into independent living for the first time in their 60s and 70s. And so those needs are certainly much different than some folks who are exiting incarceration maybe after a shorter duration of time who have spent more of their lives living out in the community. And so that is another population of interest to be thinking about. How do we support these individuals who haven't had the opportunity to live independently in the community, but may also be entering that experience with additional support needs? So, what do we know about people experiencing homelessness in general? And then what do we see when we're thinking about older adults? So, we have the highest number of folks who are unhoused on record over the past couple of years. Almost all populations across that are a record high. So, thinking about youth and young adult homelessness, family homelessness, the only demographic of folks that are decreasing the number of experiencing homelessness is veterans, as we've seen some really concerted efforts around focusing on that population. About a third of individuals experiencing homelessness are those who meet that definition for chronic homelessness, right? So repeated or experiences of homelessness or long durations of homelessness. when we look at that and compare that to older adults, right, what we're seeing right now is a significant increase in older adults experiencing homelessness. About 1/5 of our unhoused population are currently 55 and older. More than half of those who are over the age of 55 are unsheltered, which is pretty significant and high. We also are seeing that the largest age group, 55 to 62, also have the largest amount of chronic homelessness. Again, so that extended duration of homelessness or the multiple repeated periods of homelessness. And what we're also seeing, both a large share of folks with chronic homelessness, but actually 30 to 50% of those who are 55 and older are experiencing homelessness for the first time. And so that's pretty significant to be thinking about as well. So I'm going to talk through these two different populations, because when we're thinking about services and how we're going to address older adults, we have those who are experiencing chronic homelessness and aging. So what we're considering aging into homelessness, right? Somebody who's been homeless for an extended duration of time is now starting to have the needs of an older adult. We also have this population and group of folks who are older adults who are experiencing homelessness for the first time, and who don't have that history. Their needs are going to be a little bit different, and also services and interventions may perhaps be a little different. So thinking about older adults and chronic homelessness, right? You all are, again, direct service providers within the homelessness services system. So this isn't going to be new information to you, right? But we know that there are all of these drivers that are contributing to somebody becoming homeless and then staying homeless once they are unhoused, right? Medical conditions, lack of economic resources, lack of affordable housing, maybe presence of behavioral health or serious mental illness. All of those things are going to cycle together, and that without the right kind of supports or having deep social supports, people go into homelessness and they often stay homeless unless they're able to address one of these different factors. What we see happening when folks are experiencing chronic homelessness for a long time is that their health gets worse, right? The worse your health is, the harder it is for you to obtain employment, along with just like long periods of not being employed, right? When we're thinking about the employment market and moving out of homelessness, somebody who's been unhoused for 10 years with chronic health conditions is going to have a lot harder time of finding a job than maybe a 22-year-old who has a brief 2 or 3 weeks, a couple months experience of homelessness, who's able to enter back in the job market, right? The longer we're in that cycle, the harder it is to get out. We also have that combined with a lack of housing options, right? In terms of affordable housing. And then as somebody ages, a lack of housing that they're going to be able to age in place into. And what we see then is that folks are aging into homelessness. So folks who have not been able to get out of that cycle of homelessness for a number of reasons, right? Whatever their individual reasons are now aging and becoming older adults and now have the needs of somebody who's unhoused alongside the needs of somebody who is an older adult. And then we're thinking about older adult homelessness for folks who are experiencing homelessness for the first time, right? Again, we're thinking about a lack of affordable and accessible housing. Older adults are on fixed incomes, most of the time living off of retirement savings or Social Security income, right, that they've decided to take. And so that means that they can't necessarily afford more. So when cost of living increases, their income does not necessarily increase or increase in a way that matches it. Property taxes are numbers that change, right? So even if the person owns a home and the mortgage perhaps is paid off, they still have to pay property taxes and utilities, right? And maintenance of that. And the cost of all of that increase. And so it gets really hard for individuals to be able to maintain that housing, even when they own the property. So that restricted income, right, also means that maybe they don't have funds for catastrophic events that could potentially happen, that maybe require a lot of their funds. And that loss of funds and security can impact their ability to pay for housing, whether they're owning it or renting it. And additionally, then there's a limited amount of senior available housing. So there are senior housing centers available, things that folks are accessible, have access to, at the age usually of 60 or 65 and older. But those units don't match the demand, right? And so combined with a fixed income and increased cost of living, some folks are not able to afford fair market rent, but cannot access some of that more affordable housing. Individuals who are older also become homeless around when they experience the death of a spouse or a partner, or divorce that happens later in life. There's suddenly this loss of resources. Sometimes that's income related resources. For others, what we see is that when folks have been living together and are supporting each other for a long time, one person takes over the budgeting and pays the bills and makes sure that that's taken care of. If that person in the relationship is no longer there, this individual may, especially overwhelmed with grief, may not actually have the skills or knowledge to be able to keep up with some of those things. And again, that can result in eviction or loss of housing, bills not being paid, that sort of tumble into that experience of homelessness. Additional changes in family structure, whatever that might support, support and family support doesn't necessarily have to be a partner or a spouse. But if there's a change in that, people have a loss of support, or there's nobody around and they're no longer able to drive and they're not able to get the things that they need to do done, right? All of that can contribute to somebody being able to live independently in their community. And then finally, health conditions and disability, for folks who are getting older, who may have worsening health conditions, who may be more at risk for a more significant health condition, or might experience a health event, right? Something that I've commonly seen of working in direct services is an individual has a stroke, and once they've had a stroke, they're not able to return to work, but maybe they don't have retirement savings, maybe they don't have a lot of savings, maybe they're expecting to work for another 8 years, and they're no longer able to do that because of what's happened. Sometimes these individuals lose their housing while they're hospitalized because they're not paying rent or they're not making income to be able to do that, and are discharging into homelessness. The risk of having those types of health events increase as somebody's older, especially if they haven't been able to access primary care or other preventative health care services. Additionally, certain experiences of disability might worsen as somebody is older, such as vision loss, right? Or if somebody has glaucoma, things that can start to happen or more likely to happen as somebody ages. So what do we see, right? We see folks, especially those who are more precariously housed or lower income individuals, who may experience a health event, a loss of income or limited income, and then resulting in a loss of housing, and are experiencing then homelessness for the first time. So we sort of see this trajectory of folks that may be doing a lot of things. And again, it can be being a caregiver for an even older adult. And once that person dies, again, they've lost their housing because that housing belonged to that person. So there's a lot of different ways that people get there, but it often is related to one of these types of events. So again, you all are working in direct services, so this is something that you're probably more familiar with, right? Of what homelessness does to our health, right? The longer somebody is experiencing homelessness, the more likely they are to have chronic conditions, and the more likely they are to be affected by the symptoms of that chronic condition. They're less likely to be managed or to be healthier. We also see people experiencing cognitive decline, and we see that happening earlier and more frequently. So in general, people experiencing homelessness are more likely to have their cognition impacted from a range of conditions. The impact of that cognition is going to worsen the longer somebody's unhoused. We also see folks starting to have geriatric conditions. So those are conditions that we identify as ones that happen with aging, right? We see that happening, and we see it happening younger. And so that we know that folks who are experiencing homelessness age much faster, 15 to 20 years faster than folks who are housed. So somebody who is 50 years old may actually have the health of somebody who's 70, right? With those different conditions. And we can see how that might impact all kinds of things in terms of being able to support themselves financially, move into independent housing, access resources. People are also more likely to have mobility limitations, which can really impact how they navigate and access community-based services. We combine that with mental health and substance use, which we know is present in a good percentage of folks experiencing homelessness. Those are also things that don't get better the longer that somebody is unhoused, right? We see a lot more stability in symptoms and decreases in substance use when people have access to safe and stable housing. And the presence of mental health symptoms can also impact that expedited aging process. So even if folks have housing, somebody with serious mental illness also ages faster, oftentimes as a result of medications and just the impact of the health of their mental health on their physical health. So when you have all of those things coexisting, we really see people aging much more quickly, and also experiencing death much earlier. what we see then is that people have a lot of challenges with managing their chronic conditions, and they're not able to access healthcare and health services that could be supported for them. People who need skilled nursing care, who need some assistance with doing their ADLs, are not able to access that type of support. There's a lot of bias around folks who are unhoused or who have mental health conditions and getting some of those more subacute rehab and skilled nursing care needs. We also know that for the folks who are using substances, they need harm reductive approaches to care in healthcare, but they're not able to access that. And again, that can prevent them from getting some of these services that they need. And then finally, accessible environments. I've worked with a lot of individuals who finally did access some affordable housing, but the housing itself was really not accessible for them. They had a lot of trouble navigating it with wheelchairs. It was hard for them to get up and down the stairs, but they took it, right? Because they wanted housing and they wanted to move themselves out of the street or the shelter environment. But we know that there's not a lot of accessible environments. Shelters are not always accessible or always able to support people with a range of functional needs. So why does homelessness look a little bit different for older adults than it does for the rest of our folks experiencing homelessness? So again, depending on how your emergency shelter, your shelter systems were designed, they may not have been built in response to older adults. And so older folks are presenting with different mobility, functional, and cognitive needs than folks who are younger than them and who are not aging. And so that response system may not be equipped to address all of those different aspects of their needs. Individuals in their 50s may have a lot of those unmet health and social needs, and may not qualify for some of those services that are available for older adults. And so a lot of times when you see services, 58, 60, 65, right? That's the minimum age that people need to be able to get those services. But our folks who are unhoused really might functionally need those supports and services in their 50s, in their early 50s, but they can't access them. We also see, just like we see in other places, kind of some siloing of services. So older adult services and programming are not always connected with the homeless response system. Somebody who's unhoused may have trouble accessing some of those supports and resources that are intended for folks who are older. It also can be really hard to discriminate between what is behavioral health and what might be something happening neurologically or cognitively for the person that is more related to their age and decline in that type of health than it is behavioral health. So there's a lot of symptomology in behavioral health conditions that also look like neurological conditions. So somebody who's had a stroke, and if folks don't know that they've had the stroke, that person may appear to be intoxicated. That person may not have a lot of motivation or initiation, and we might chalk that up to some behavioral health or motivational issues, when really it's something more cognitive happening in the brain. Again, we find challenges for older adults in general in the broad population that have mental health or substance use disorders or needs, that those typical, again, aging in older adults environments are not as structured to be able to support all of those different factors of the individual. And then finally, right, we talked a lot about early mortality, but people really need end-of-life care support services. And again, that's not always accessible to folks who are unhoused, and the homeless response system is not really built and set up to support people who are at that phase of life. So that's a lot about kind of what the issue is currently. I would be curious to know if anybody wants to throw in the chat if you are seeing any more folks who are experiencing, older adults experiencing homelessness, if that is something that you're seeing and the demographic and population that you're serving. Just be curious to see if that is something that you all are noticing, or kind of these needs and issues that we've brought up here, if that's something that you're seeing. Yeah, so one of you, yeah, thanks, Christina. Yeah, okay. Yeah, so definitely something that we're seeing. So this next section and chunk of content is to kind of talk about how we can approach and support older adults experiencing homelessness. And again, there's a lot of new work being done around this because it's a new and growing issue that has really kind of started happening within the past couple of years. So we did a lot of interviews with different providers, but so we really like this quote from a physician who's a geriatrician in San Francisco, right? So there's a degree to which health and social support needs aren't different in character or quality than the general older adult population, but the things that people are managing, right? The health and social support needs of older adults become more manageable in a scenario where people don't have access to stable housing, a support person, and those things that help you manage your chronic conditions, right? So managing aging can be challenging but doable. But when you have that lack of access to resources and support systems, it can be really hard. And one of the things that we are always balancing, right, I think in general, with the population that we're talking about, is sort of how do we facilitate independence and autonomy in the person, and what is the right amount of support that that person needs, and thinking about safety, right? This question comes up a lot. Can that person safely make their own decisions? And it's less clear with some individuals, and it becomes more challenging as somebody is older and potentially experiencing some of these geriatric conditions. And so there's not a perfect strategy to help navigate that, but just to note kind of that balance and tension of like facilitating independence and recognizing where folks are independent, and then identifying and being able to provide the support needs that they need. So just in general, right? So here's some guiding principles for services for people supporting older adults. And these are just really helpful to remember, but especially important with this population, right? Accepting people as they are without question or requirement, but also recognizing that people are the authority on their own life, right? So we don't always need to direct or be the answer for the person. Sometimes our role is to support them in navigating those choices, even when it's challenging to witness, right? Sometimes people are making decisions that are hard to see, but we need to allow them to make that choice. But we need to remember that that's an important part and something that they have a right essentially to be able to do. Um, Homeless services is a lot about relationship building, right? To make progress and identify the person's goals, you need to have a relationship with them to really understand what those needs and priorities are for themselves. Um, and being able to help that person and have them trust you to be able to assist in those decision makings. This is especially important in older adults, not just in folks who are unhoused, but when people start to appear a little more frail, a little sicker, right? A lot of times people want to tend to step in and sort of guide what the decisions are, right? You see this within families. I don't know if any of you have supported an older adult in your life or caregivers in that way, but there's a lot of challenges, right? What happens when the adult children say, we don't think mom or dad is safe to drive anymore, right? And the parent is like, no, I want to be able to drive. I want my independence, right? That causes a lot of tension in families, and that certainly can come up in homeless services as well, especially when you're not in that family position and more of the provider role. So we want to continue to maintain our approaches, right, around trauma informed and trauma responsive care, recognizing people have the ability to make their choices. We want to work collaboratively with somebody. Sometimes it takes a little while, and sometimes people will end up making a different decision than you expect, and one that you would like them to make, but it just takes that conversation and time to be able to do it. We're thinking about how do we manage safety for everybody involved and what those power dynamics can look like when we're in that provider or staff role versus individual role. So not a surprise to you all, right? Trauma-informed care is really important in terms of services. We know that unhoused adults in general have higher rates of trauma and traumatic experiences. But we also need to recognize, especially with older adults, that the trauma may be really, really recent and may be related to why they're experiencing homelessness for the first time. Again, if they've experienced a loss of a spouse, a partner, family member, whoever it was, and that loss was a contributor to them becoming homeless, that's very recent, and people may be functioning in very acute grief. Similarly with a significant health event, right? When somebody's health status really changes, one, it might be scary, it might be a near-death experience, but they might also just be in that process of accepting a particular new limitation or, kind of diagnosis that they might be managing. If somebody has recently learned that they have mild cognitive impairment, which makes them more at risk for dementia, like that's a lot to process. Cancer diagnoses like amputation, right? So we need to be aware not only of long-term traumatic histories, but that there might have been a really recent traumatic event that caused the homelessness and why that person is engaging in our services. So there's an approach to an age-friendly health system, and it's called the 4 M's, and this is a way to help think about how we approach the different needs around older adults. And so part of it is what matters, right? And this again is really responsive to trauma-informed, client-centered care, whatever that approach might be called in your organization, right? Is that we want to align with the person. We want to identify what their priorities are and align our care and care plans around that across what those different preferences and needs are. We also need to be thinking about medication. Even if you're not a medical provider or a direct provider, it is very easy for older adults to be over medicated. And so changes in function or changes in cognition that we might witness in our shelter environments and day center environments might be related to the impact of the medication the person's being prescribed. And so being able to communicate those changes and help the person, be able to navigate that with their healthcare providers can be really, really helpful because medications will have a different effect on older adults, and also because they might be managing more conditions that have medication. We also want to be aware around mentation or somebody's cognitive health, right? Certainly, we want to be monitoring for those cognitive changes. And again, connecting, if you're not the healthcare provider, connecting folks with their healthcare provider to manage that. Older adults are more likely to experience delirium, which can again be effective medications from infections like UTIs, and sometimes it looks like dementia. But when we actually treat that underlying health condition, the person, their cognition improves and their function improves along with that. We also need to be on the lookout for depression. Depression is more common in older adults and can have, again, another big impact on their cognition, their motivation, and can look like other things. So maybe we need to make sure that they're getting treatment for their mental health to be able to support their functioning. And then the last one is to look at mobility. We want to make sure that people can move and get around and do what they need to do. And mobility around functional mobility is how the person moves. And so in our programs and services, again, thinking about how do we make our spaces physically accessible for folks, like to make sure people can get through the building safely, but also connecting people with resources and services so that they're safe when they're moving around in the community, making sure people are getting the right walkers or wheelchairs or access to PT or things that are going to help address that. And so how do we figure out what those are and thinking about this? So and this is, I'm going to go through some of the more medical piece of it, recognizing that you all are not necessarily medical providers, but you're the people seeing folks day to day, right, in their day-to-day lives, and recognizing when these things are starting to come up and can maybe be helping that person connect to services or communicating around what their needs are in that environment, because older adults don't always want to talk about what's going on in part because they're worried about a loss of independence. They're worried about a loss of autonomy, right? Of like, oh, if they think that I can't take care of myself, I'm not going to be considered for housing. And so sometimes you can help build that trusting relationship to say, hey, like, we just want you to help feel better and to be able to do what you need to do. Let's get this checked out. So what are those different things that we're looking at? We want to be on the lookout for hearing impairment and visual impairment. Hearing loss and vision changes can look like a lot of other things, right? And what's actually, if we can correct some of that, again, people's function and mobility might improve. Not having your hearing addressed actually increases your risk for experiencing dementia or other cognitive related changes. Sometimes hearing impairment can also look like the person's not paying attention or responding or following directions when really they just need their hearing checked. So those are two sort of low level things that getting folks into screening clinics and accessing that can make a really big difference. We also want to be on the lookout for things like cognitive impairment, right? People who are demonstrating memory issues, attentional issues, disorganized, not really able to follow through on routines, keep up with themselves or keep up with their stuff. That can be a result of cognitive impairment or functional impairment. So again, getting that checked out to figure out what's going on, because sometimes it's a condition that can be managed, that those things can improve. And if not, we want to start that long-term process of thinking about what long-term care might look like for them. We also want to be on the lookout for incontinence. Incontinence is a huge challenge, again, in our unhoused population. People are dealing with incontinence because of the medical conditions that they're experiencing, but also the situation of homelessness actually triggers incontinence symptoms, things that are really bad for managing your bowel and bladder or having to hold it or not being able to clean yourself properly. All of those things that happen to folks when they don't have access to a bathroom. So we're going to see a lot more people experiencing incontinence in our programs and shelters. And so thinking about how do we set up our spaces to help people be able to manage that, access supplies such as Depends and wipes, clean underwear when they need it, making sure that we have bathroom access, that access is accessible for folks to use, right? Thinking through some of those structural things, but noticing again when it's happening, because there are interventions and medical treatments that can help somebody when they are experiencing that. And we know that repeated episodes of incontinence can keep people from shelter settings. And that's one of the reasons why we see a lot of individuals with disabilities and older adults actually living unsheltered. If you remember back to that early statistic, right, 30 to 50% of people who are unsheltered, a lot of that has to do with mobility and incontinence, and falls, right? So going back to that mobility piece of it, we want to, one, set up our environments in a way that prevents people from falling as much as possible. But if somebody is experiencing falls, we want to connect them to services, again, that can maybe address what's going on. Sometimes it's, again, addressing just vision and hearing can reduce the risk of falls. Sometimes it's getting the right mobility device for them. And sometimes it's accessing larger services to address what might be going on for an individual. So I use the word functional limitation. So defining functional limitations here, we're talking about functioning. We're talking about the interaction between a person's health conditions, their environment, and their person factors. I really like this definition because the environment is a really big piece of it, right? We all have our individual skills, abilities, and the way that our bodies are put together, move, and function. We have our health conditions that influence that. And how we are able to interact with our environment is dependent on how the environment is set up, right? Somebody is going to experience more functional impairment if they're a wheelchair user, if everything has stairs, right? They're going to be prevented from doing a lot of activities versus if their environment is more accessible, they're not really going to have a lot of functional limitations. So here's a list of a lot of ADLs: activities of daily living, bathing, toileting, dressing, feeding, mobility, and hygiene. Those are different than IADLs, so instrumental activities of daily living. When we're talking about IADLs, we're talking about getting around in the community, driving, taking the bus, managing finances, meal preparation, responding to safe emergencies and safety concerns, shopping, communication. So I think that's really helpful to differentiate because a lot of times where people start to struggle first is the IADLs and not the ADLs. And so again, we're seeing a lot of folks who maybe are experiencing homelessness for the first time as a response to cognitive changes or early onset of dementia, where suddenly those more complicated activities such as managing bills and going shopping and taking care of the home, that's what starts to go first. And so even if you're working in a permanent supportive housing environment, kind of monitoring those changes can be a really big indicator that something's going on with the person, and we maybe need to intervene or address what that is. By the time that somebody's having challenges with their ADLs, especially related to cognitive issues, it's likely that has been going on for quite a long time, right? When there's physical limitations for ADLs, it's a little different, but people with just physical limitations and no cognitive limitations often can identify some workarounds and need more adaptive strategies. So keeping an eye out on these different activities and where folks are struggling can be a flag to say, hey, something's going on. And, suddenly all of a sudden somebody's not doing their ADLs anymore. That's interesting. We want to explore what's going on there. So how is this impacted? How are ADLs and IADLs impacted when somebody is unhoused, right? Shelters are not always accessible or not always meeting ADA guidelines for accessibility in their sleeping quarters, in their bathrooms. Sometimes they're lacking a space to do self-care or health management, right? If you have to take 20 different medications, that's a lot harder to do if you have a bed that's in the middle of a large congregate facility and it's not quiet and you're nervous about what other people are seeing, not a safe place to store and sort and organize that can be more challenging. And when you're not able to use a skill, it's harder to maintain that, right? That idea of use it or lose it. So if somebody hasn't been doing an activity for a long time, they may kind of lose that skill and ability to do it, but they could regain it with practice and support. People may have challenges accessing different resources. Again, the mobility concerns and maybe cognitive changes make it harder for them, especially if they have to navigate through multiple different resources at one time. So the county that I live in Florida, there's not one central place where people access their resources. They're sort of spread and disparate. And so people have to know, well, I can go for lunch on Monday, Wednesday, Friday at this church, but I have to go to this soup kitchen on Tuesday, Thursday. This day is, a place where I can go do laundry, but it's only every other week. That starts to get really hard for people to manage and navigate, especially with those other challenges. People have a really hard time accessing durable medical equipment and adaptive devices that might be really helpful. Those are not covered by insurance. People have to pay out of pocket for that a lot of times. It's hard to store it, especially if it's bulkier. So things that might help the person function, maybe not accessible. Power wheelchairs are great, but you have to be able to plug it in to charge it. And so that might not be a resource that's available to somebody who doesn't have a place to be able to do that. And so when this last bullet around bidirectional relationship of functional impairment and behavioral health symptoms, right? Our behavioral health impacts our ability to engage in day-to-day activities, right? If we are feeling more depressed, if we're feeling less motivated, if we have some delusions or psychosis that's present, right? It's a little more overwhelming. It's hard to get going through the day. But when we experience functional decline, right, those symptoms can also get worse. So suddenly, if you're not able to care for yourself in the way that you need to, you may start to feel more depressed, more anxious, more distressed. If you've experienced a fall, you start to have more anxiety about that. You might restrict your activities. Suddenly, I'm restricting my activities. I'm not moving around as much, and that my movement's getting worse, right? So all of those things really play in together. We want to encourage participation and activity in folks because that's actually what keeps us healthy. So what do we do about it? Again, this is a little bit more of the medical side of it, which I know not all of you are functioning in, but there are still some things that we can do regardless of your service level. First and foremost, just assessing your services and figuring out how easy are they to access, both physically, but also from that cognitive perspective. Is it clear when people can come in to get our services? Is it clear what we offer? How do we make sure that somebody can call and find out information versus show up and get information about that? And then mobility wise, like, looking at how far away are you from the bus stop? And is that walk accessible for somebody who has a cane, a walker, a wheelchair, who might need a break while they're walking that distance? How accessible is my actual building? Can people get through it? Can wheelchairs fit through the doorway? Some of those simple things to make sure people can get to our services. And thinking about, if you can, some environmental modifications. Construction is expensive. If you're doing homeless services, sometimes you're functioning in the space you have, not the space you want. But think there's some simple things that can happen, right? If you have bathrooms, you can put grab bars in every shower stall or every bathroom stall to make that safer for people to use. It's pretty low cost, simple to do, and can just help create that space more accessibly. And then thinking about maybe more long-term solutions around, how do you create that space? And then ensuring that you're using trauma-informed care strategies. That trauma-informed care makes a space accessible for a whole range of individuals, especially from that trauma perspective, but also the cognitive perspective, right? If we're not making assumptions about why somebody is or is not doing something, and we just accept them as they are, that's going to make our services more accessible. If you're at the service provider level, or if you're thinking about building some partnerships with service providers, think about how you can bring folks in who can assess for functional limitations. So is there a partnership that you can build with an occupational therapy, physical therapy program that can do some assessment and evaluation, provide some recommendations or intervention with folks that need it? Bridging technology gaps. Older adults, we'll talk about this in a minute, are not always as comfortable with using technology. So making sure that, again, having your services be accessible in a range of ways, not just on a website, but having a phone number, again, answering questions for people who show up because they maybe are not using some of those online resources or applications. Having staff available to help navigate those systems can be really helpful. And then when we're talking about transitioning folks into housing, we want to make sure that we're advocating again for functional assessments and identifying modifications and supports that will make housing successful. I'm an OT, and so I talk a lot about this. Just because there's a functional limitation does not mean that the person is not going to be successful in housing. It might just mean that they need a few different modifications or supports to make that work for them. We don't want people to not get housed. We don't want people to spend 30 years living in a nursing home when they don't have to, when we can provide some supports and services to help make that transition a little bit easier. Sometimes it's things we're already doing, like rep payee services, and sometimes it's thinking a little bit outside the box of connecting folks with senior transportation services or hiring a house cleaner that will come help the person or help clean the person's home, a couple times a month. Whatever that might look like, there's some creative solutions that we can do if we can identify that early on, what supports the person will need. Making sure there's a shower chair, right? Asking the landlord to install grab bars, really basic things that can help people age in place successfully. So I've talked a lot about cognition and cognitive decline. So I'm going to provide a little bit more context about what we mean when we talk about that. So cognition is information processing functions that are carried out by the brain. So this is just a sampling of cognition. Cognition is our thinking skills. It drives what we do, how we act, how we respond to situations, how we problem solve. And that includes things like attention, memory. These are the things that are most familiar to people and often what they recognize that they struggle with. I have so many folks who come to me, I can't remember anything. I can't remember what I need to do. That's often a sign for folks that something is changing. Executive functioning is that more complex skills, being able to know I need to do something, get what I need to do to start it, sequence the steps in the right order, finish it, right, and make sure I've completed it to my satisfaction. That's executive functioning. And so executive functioning, again, starts to get impacted first because it's harder, it's more complex. And that's why we see those changes around health management, bill paying, cooking, those higher level activities is where we start to see cognitive decline first. People also may have communication and speech skills affected, visual perception. So kind of, being able to say like, there's a cup of pens and this is how far away it is. And I need to reach to be able to do that. That can be affected a lot by vision changes. And then praxis is really about our motor skills and movement. So why do we see cognitive impairment? Again, I noted this earlier, but people experiencing homelessness have higher rates of cognitive impairment in general because of chronic health conditions. They're at more risk of experiencing brain injury. About 50 to 70% of people experiencing homelessness have had at least one brain injury. Behavioral health conditions can also impact our cognition. The more acute your behavioral health symptoms are, the more your cognition will be affected. Substance use, both actively using substances, but also a history of substance use, especially alcohol, can have a lot of impact on our cognition and our brain health. Also, stress. Cognition is really impacted by stress. If we're not eating well, we're not sleeping well, and we don't have a safe place to stay, our cognition is also going to decrease, right? I think we all can relate to that. If you've had a bad night of sleep, you sort of feel foggy the rest of your day. That's a lot of times how our folks who are unhoused are feeling because they're not getting good sleep or they're experiencing pain. So sometimes we're, again, resolving that environmental piece, meeting safety and basic needs, their cognition can improve. And that's why we want to avoid sort of that overdiagnosis and overassumption and really get to the root of what's happening with somebody. What that means, though, is if you do have cognition affected, it makes it really hard to navigate our healthcare and housing systems, right? I've been doing this work for a long time across multiple states, really understanding systems, and systems are hard and complicated. And, even as a healthcare provider, learning about my health insurance yesterday was complicated and confusing. So when you have a cognitive impairment, that's even harder. We see a result in that, and folks who have cognitive impairment stay unhoused longer than folks without because these systems are so challenging to navigate. They also put folks at higher risk for victimization or being taken advantage of by others. And when the cognitive impairment is really present, sometimes people feel really uncertain about housing them, again, with concerns of safety. But there's not really a gap, right? There's not any sort of support in between PSH or independent housing and institutional level care. And so a lot of times people are hanging out here, just sort of without anything, which can make it really challenging. And why we see folks living homeless longer. So again, if you're not a medical provider, this is less relevant, but this can be something you can communicate and advocate for, is screening for cognitive impairment. There's a number of screenings and screening tools that are available to look at dementia and cognitive impairment in general. That screening is not necessarily a diagnostic tool. It can tell you then that there is an issue with cognition that a provider can further explore, because doing poorly or having some challenges on a cognitive assessment does not always mean that it's dementia. It could be that the person had a head injury 20 years ago. It could be that the person has learning disabilities that we didn't know about because we don't have school records, right, from 30, 40 years ago. And it could be that there's something changing. And so we really want to involve care providers and medical providers in identifying what that is, and then identifying what the appropriate supports are. You can implement a lot of strategies for cognitive impairment to be able to support somebody living in the community until they're at the point of progressive dementia. Progressive dementia, the person is going to need more support over time, and that's when you're looking at different housing situations. But for other folks, you can really figure out how to keep them supported in the community. But as the people who are seeing folks day to day, you might be the one noticing that change in cognitive decline. The person might start talking to you about it. And so having a sense of that and getting folks connected to the right resources can be really helpful. So again, thinking about complex medical management, even if you're not a provider, there's some things, again, that you can do to support the person. providing a safe space for them to complete chronic health condition management, right? Do they have a safe place to sort out and take all the different medications they might be taking? Can you support them in accessing? They may have more medical appointments, more follow-up, more specialty care that they need to be managing, more dieting recommendations. How can we help support that? Getting good sleep, whatever that looks like, being able to help the person follow through on that medical plan. We also need to have the conversation or introduce the idea of advanced care planning with individuals so that they can make decisions about their care if a significant medical event occurs or at end of life. You can do that as a direct provider or as a shelter provider. Even there's resources, I think, that are linked at the end of this to walk through that conversation. You just might be the person that they trust to do it. They might not trust their doctor in the same way. And so you can get that process started with them so that we don't end up in a crisis situation where somebody's hospitalized and they're saying, well, what do we do? What intervention do we do? You knew the person best. What do you think? And we don't know. So that advanced care plan can really help identify and meet that. So I think I talked a lot about these different strategies, right? From the service provider perspective, if you're not a medical provider, it's a lot about just making sure you have capacity to do care coordination, knowing that there's going to be more potentially for this population, that they're going to have more medical needs to be able to support, and be thinking about that. And also thinking about when we're transitioning folks into housing, building in some of those extra supports as they make that transition as well. Home health care agencies, things like that, that may be more supportive for them. And then if you can, providing some supportive strategies like, a pill box or having the person see if they can get a blister pack covered by their pharmacy so they don't have to remember to take all their medications in the same way. Identifying who those support folks are, who's their emergency contact, all of that kind of stuff, like kind of that care, that case management that surrounds people with a lot of medical needs, being part of those advanced care planning discussions, or educating the person that they can have those discussions with their doctor. And then we're going to move into behavioral health needs, but I'm going to pause for a moment there and just see if anybody has any questions or thoughts around kind of the cognitive functional medical piece before we dive more into the behavioral health part of it. All right, I will continue on, but if you have a question, if you are in the middle of typing, please finish it and we'll definitely have time to get to it at the end as well. So again, you all are direct providers working in homeless services, so behavioral health is not going to be new to you, but we are going to think about behavioral health conditions in the context of older adults here. So when we're talking about behavioral health, we're defining that as the promotion of mental health, resilience, and well-being. We also are thinking about the treatment of mental health and substance use disorders and the support of those who experience or are in recovery from these conditions. So this is the definition put forward by the Substance Abuse and Mental Health Services Administration, SAMHSA, right? So mental health, when we're talking about mental health, we're talking about how it, kind of our overall mental well-being, and how it impacts our day-to-day functioning, right? It can impact our ability to engage in productive activities, have healthy relationships, an ability to adapt and change to adversity, depending on what those symptoms are that we're experiencing. When we're talking about substance use, we're talking about the use of selected substances with possible dependence and other detrimental effects. So when we say substance use, we're not always meaning addiction, right? Or substance use disorder. It becomes a disorder, a diagnosed condition, when it is impairing somebody's ability to engage in functional activity, they're at risk or they're engaging in risky or harmful activities, and it impacts their social and interpersonal relationships. There's a lot of people who use substances of all kinds who do not have those impacts, and there are certainly some who use substances that it becomes a disorder because they're dependent on it, and it's impacting their day-to-day routines. And so we just want to think about that because especially with older adults who have been potentially using substances for a long time, we're not going to get to total abstinence, but we can think about how to support them in a way that's safe. So thinking about behavioral health for people experiencing homelessness, again, we noted that at the beginning that there's higher rates of behavioral health conditions amongst people who are unhoused. behavioral health conditions can contribute to a person becoming homeless, right? If their behavioral health symptoms impair their ability to maintain their home, work, or have an income that they're able to afford housing. But we also know that people develop behavioral health conditions after becoming homeless. People are more likely to experience symptoms and worsening symptoms of behavioral health once they are unhoused because of the stress that happens when you don't have a place to live. Um, so, and the trauma interplays in that, right? Like trauma can create or cause a behavioral health condition that then contributes to homelessness. Trauma can also happen after somebody is homeless, making the behavioral health condition work and again worse, and then again harder to transition out of that situation. So it's a very vicious cycle that folks can get stuck in. Behavioral health has a lot to do with how we experience our physical health, right? If you have depression or a behavioral health diagnosis, your experience of things like pain may be more significant, and those two things together make it really hard to engage in day-to-day routines. So what does this look like again for older adults? Depending generationally, there's going to be a little bit more stigma around behavioral health, both in terms of the population itself identifying that they're experiencing mental health symptoms, and also that they are going to and wanting to talk about what those are, right? If we think about folks right now who are in their 60s, 70s, 80s, mental health was not as open, right? People didn't talk about it. It was seen as very detrimental. And so when somebody's experiencing that in that generation, they're not going to be willing to talk about it, share what's going on. They might not even know that there are resources that can help them with that. And so one is overcoming that individual stigma. Some of it, they may be experiencing that behavioral health symptom for the very first time as a response to that loss that they might have experienced, of housing, of partner, of family, of social supports and friends and networks there. Sometimes people experience that loss or worsening symptoms just after retirement because that's such a big change and transition. It may also be related to new medical conditions. Again, neurological conditions can have mental health symptoms be part of it. So they may start to have worsening behavioral health or mental health after a stroke, after a diagnosis of Parkinson's, right? Any sort of change like that can impact that. Older adults also are going to respond differently to medications than younger adults do. And so the prescribers have to be really careful about what they're prescribing to help manage somebody's behavioral health when they're older. For somebody who's had a behavioral health condition for a long time that's managed it. So I worked with a woman who took lithium for forever to manage her bipolar disorder, and it worked really, really well. Well, after being on it for 20 years, she started experiencing lithium toxicity. Part of that was just being on it so long, and part of it was just aging. That she had a lot of trouble managing her symptoms because they had to do all these medication changes for her. And so there was these worsening side effects that she experienced. It was a really challenging situation for her, and very frustrating because she had been able to manage this for quite some time without having any issues. And it resulted in a lot of hospitalizations and things. And then similarly, again, we've talked about this with cognition. Behavioral health symptoms can look like cognitive issues and dementia. And so a provider has to tease out like what is happening from might be a behavioral health condition versus what might be a cognitive change that we need to monitor. Sometimes it's both, right? We see mood and behavior changes in folks who are experiencing dementia. But again, we can't prescribe the same medications to help manage some of that. And so it gets a little trickier and more complicated as we need providers on board who understand older adults and geriatric healthcare and geriatric psychiatry to make that really work. Similarly with substance use, right? So a lot of times substance use is under-identified in older adults. For whatever reason, we sort of have this social perception that substance use and substance use disorders don't affect older adults. And that's very untrue, right? Some of the triggers for substance use and substance use disorder are more prevalent amongst this population. Folks who are lonely, folks who maybe are not socially engaging, who are more isolated, who aren't leaving the home, might be more likely to use as a response to that. We also know then that long-term substance use can impact cognition. So this is very clear with alcohol, that folks who have heavily used alcohol for a long time might start to show signs and symptoms of cognitive decline as related to that. Older adults who are using may have a fear of withdrawal and may not seek out care because maybe, again, if they've been using for a long time, they might have gone through that over and over again and might not be interested in experiencing that. Withdrawal is very uncomfortable and painful, or detox is uncomfortable, that sometimes that's demotivating to engage in that. And also that what comes up a lot, especially when we talk to older adults, is that treatment options are not always appropriate for older adults. And so if you have somebody who's 65, they don't necessarily want to go to a substance use or recovery program that has a lot of people who are in their 20s and 30s, right? It's not their peer group, and the situation is going to be different. Causes are going to be different, responses are going to be different. People who've been around the block a few times, like, don't necessarily want to go through all of that. And so sometimes we need to be thinking about what are the more appropriate treatment options for someone of that age? Where are they going to be more comfortable with that? And if it's the first time seeking treatment, right, is it age appropriate? Are there people there who are their age? Even just in terms of their support counselors or peer recovery counselors, again, a 65-year-old maybe isn't going to make the same connection with somebody who's 28 in that role as they might another older adult. And then again, once you start to think about cognitive, functional, medical comorbidities, it's much harder to get that substance use treatment, right? If somebody wants to go into a recovery program, their medical needs need to be stable. And that may be much harder for somebody who is an older adult if they have other chronic conditions, if the spaces are not accessible, again, for mobility devices. Again, that programming being built out for a younger cohort is not always prepared to support somebody who's older. So what can we do from the service provider level? Again, thinking about how do we just make sure that our services are open and accessible for everybody? And so, do we have to have requirements around sobriety? Older adults who have been using for a long time are much less likely to move into sobriety and recovery than younger adults. And so that just may not be a realistic goal. If you have somebody who's 68 who has been using almost their whole life, our goal of sobriety might not be realistic. How do we engage them? How do we support them regardless of that? And again, when we're moving into end of life care pieces of it, how do we make sure that end of life care services in our community are able to support people who maybe do have a history of behavioral health or substance use, demystifying that and addressing some of the stigma that goes along with it. Again, from the service provider level directly, as we have folks who have substance use disorders or behavioral health disorders as they're aging, we might just need to increase the frequency of engagement. Again, thinking about how we can hire a peer support workforce that is across the age span, right? Not just younger folks, but who are older adults in our community that might be interested and willing to work as peers to make that connection with our folks who are unhoused. Making sure, again, that people are educated around what is behavioral health, and trying to use harm reduction approaches and advocate for that in our older adult systems that are not necessarily working with folks who are unhoused all the time. All right, and then our last sort of chunk or section here is around identifying and addressing social needs of older adults experiencing homelessness. So this might be a little bit more your wheelhouse than the medical stuff. And again, thinking through, we're going to talk through some of the barriers and then ways that we can address that. So when we're thinking about moving older adults who are homeless out of homelessness, there's a few different unique considerations. One, again, we need to think about what services, resources, programs, housing, are they equipped and set up to support people who have different mobility, functional, and cognitive needs? Again, the presence of functional impairment or the presence of cognitive impairment does not mean that the person needs to move into institutional level care. Sometimes it's just a different set of supports and strategies to help that person function in the community. A lot of older adults talk about the challenges with technology. Many things have moved to technology based. It's very hard to get a person, and older generations did not grow up with technology or not as savvy about it. And so still want to be able to call somebody and talk to them on the phone or want to go to a place to be able to do something. They don't necessarily feel comfortable, doing things online. And we know that older adults are more susceptible to scams and other things because they don't understand or are not as familiar with technology. So building out technology literacy so that they can access the resources they need, but also to protect and maintain their safety. We also need to think about, there's a lot, of language that gets thrown around in homeless services around building people back to self-sufficiency and building people back to independence, right? that's maybe not a realistic goal for an older adult. If you have somebody who's 62 with chronic health conditions, we need to be thinking about long-term income supports that are not related to work for them. Return to work is not necessarily an appropriate goal. So we need to be thinking about that and how we're managing services and systems. Some current challenges is that there's sort of these two bodies of work, right? There is older adult services, like your area agency on aging, and then there's our homeless response system and our continuums of care. And those two things are not necessarily integrated or communicating or partnered with each other. And so some folks might need both of those things, but they can't access them because those services are not built in together. And then finally, when we're thinking about placement options for older adults, especially for those who do need a higher level of care, like assisted living, those places are not necessarily set up to support people who do have substance use or chronic health support needs or mental health support needs. So here's some things that we can think about doing with that. Transportation can be a big barrier. Again, folks, even if they're able to take the bus and navigate the bus system, it can be challenging if they have to walk a long ways to get to and from bus stops to even get on the bus. Not all bus stops have benches, right, or covers or things that the person can sit down on that they may need to. And so if the bus system physically becomes hard for folks to navigate, what are the resources available? How do we get folks set up for paratransit services or mobility services so that they can get rides? Are there other services, senior-based services, healthcare based services to help people with transportation? So again, even if the person knows how to do it physically, that could be more challenging. Again, technology, right? Sometimes it's just having additional hands-on support to navigate systems where you have to do things via technology, computer, but also education so that they can maybe do some things on their own. Again, around safety, making sure that they're safe, that they're not getting themselves into trouble, that they can understand and respond to scams appropriately or not respond, right? We don't want people to answer answer those messages that people get. So sometimes it's education and sometimes it's just like compensating and being the technology resource for that person, depending on what they want to do and what they're capable of doing. When we're talking about personal self-management, again, when we have some more physical limitations for folks, they may just need more help. If they have limited mobility, they're not going to be able to get down and scrub hands and knees the bottom of a bathtub, right? Or they're not going to be able to use certain types of laundry machines. Wet laundry is heavy, it's hard to lift, you got to put it in, bend over, reach, put it in the dryer. So like even just having different types of laundry machines at a facility can make it more accessible. And also thinking about what resources exist to provide some compensatory supports for the person. Again, if we're thinking about housing folks, like how can we build in some home cleaning services to help maintain their spot so that, again, they don't have issues with bugs and cleanliness and eviction around that when we know that the mobility limitation exists. And then thinking about social needs and social networks, right? We don't want people to be lonely and isolated. What are the things that are available in our communities for seniors that we can connect people to? Many communities have senior centers. That's one of my favorite field trips to go on with a person is to take them on a tour of the senior center and they can see, they can socialize. They do day trips from senior centers. They provide meals there that are really cheap. Like people can eat for $2 a day at some of those settings. And so they also may have transportation. So getting folks connected with that. YMCAs often have senior-based programming, senior-based exercise groups, and they do income-based plans for folks to become members there. So really researching what that looks like. Religious organizations do a lot of things for older adults. So figuring out what is there in your community, and again, that peer level age related support system can be so important, especially if the person has experienced some grief and loss and lost those connections, lost those family supports, those peer supports they might have had. That reconnection can really mean a lot. Increasing social engagement is really good for people's mental health and actually their physical health. And that can be really critical long term. Also, when it's appropriate, doing family reconnection to family or friends when appropriate. If somebody has become isolated, sometimes because of embarrassment around their mental health symptoms or maybe around their situation, there's a lot of older adults who quietly slide into homelessness and the supports in their lives don't even realize that that's what's happened. Again, from talking with this community of folks, some of that is generational of not wanting to ask for help or not wanting to let people know when they're struggling. And so sometimes doing that reconnection point can really be a game changer for folks and working through that. So I'm going back to our 4 M's that I mentioned many slides ago, just to give some examples of what that can look like from the homeless services provider perspective, right? So the 4 M's: mobility, right? Helping the individual move safely. We might recognize that somebody is struggling to access the bunk bed system, and we might make sure that then they have access to a lower bunk for sleeping because they have a hard time climbing up on a top bunk. Maybe as a community health worker, you support a client in getting an electric wheelchair. Maybe we've identified they have a place to plug that in, and that's going to improve their mobility, ability to take public transportation. So we can support that mobility process by navigating those resources. Similarly with mentation, right? So identifying and managing behavioral health symptoms and cognitive decline. A peer might notice that somebody keeps getting lost when going to the bathroom, right? So starting to have trouble navigating locations, both unfamiliar and familiar, can be a sign of something happening cognitively. So we might, again, notice those disruptions or changes in routine that can say, hey, we maybe need to get this assessed or get this person connected to services. A benefits coordinator might just make sure that they have extra time to help somebody complete paperwork, whether that's online or in person. If we note that somebody is having some of those cognitive challenges, getting fatigued really easily, we will set aside more time to be able to support and work with that person. Medications, making sure medications are safe and being taken safely. Again, even if you're not a prescribing provider, you can help support folks in this. You might join a person at their appointment to help them explain like what symptoms or side effects they're experiencing from their medications, what challenges they might be having with managing the medications, and being able to problem solve how we can make that easier for the person to do and to manage. As a peer navigator in the program, you might help pick up their weekly pill box or their blister pack, having the person ask the pharmacy for easy open tops, right? If somebody has arthritis, those tops are hard to open. So just figuring out what those support strategies are for that individual. Again, and then what matters. I think this is the easiest one of the 4 M's, where it's more naturally what we're already doing in our practices and services, is making sure that we're centering care around an individual's goals and preference, right? So being supportive, being listening, able to listen to folks when they're addressing these new challenges that are related to aging, reconnecting folks with family. Again, a lot of times when people are nearing end of life, they're more interested and willing to connect to some of these more distant resources. And so really being able to help identify what those resource needs are for the individual, what their priorities are, and helping them be able to navigate that. Um, so when we're thinking about that housing transition, and I've woven this in through many parts of the conversation, but there are some real challenges in terms of figuring out what the right housing is and making that happen for those individuals. Again, when somebody needs a little bit of a higher level of care, assisted living, boarding care, even sometimes nursing care, nursing home care, that can be much, much harder to navigate when the person has a substance use disorder, a mental health disorder diagnosis, even when those things are managed. Sometimes just having the presence of that on their chart in their medical history can make folks less likely to take them. And so that requires extra advocacy and support and resource building to be able to do that. Um, Again, accessing skilled nursing and long-term care, both for managing conditions, but also for long-term placement. There's a lot of barriers to that, especially when folks are on Medicaid, in addition to any of the conditions they might be having. And again, lack of the right housing unit, right? So I spoke about like accessibility and aging in place. Having that available, it can be a game changer, but that just may not be available in the community that you're in. We know that there's not enough accessible housing throughout the United States. And sometimes people also may benefit from shared living environments, right? There's not necessarily situations in which somebody gets a housing voucher and they can have their adult child live with them, even though that adult child could provide a lot of supports and services. The voucher is just for that one individual. And so then you're stuck trying to figure out, how can you build in all of those different supports and resources? Multifamily and multi-generational living is a really great way to help folks age in place. That's generally not available through our HUD funded housing options. So that can be really, really hard. Additionally, program supports and services, we talked about, supporting people with IADLs, instrumental activities of daily living. your programs have to be built out to be able to do that, right? If somebody needs budgeting and rep payee services, you have to have the number of staffing to be able to effectively manage that for folks. If people need some help with shopping, grocery shopping, or simplified meal prep, you need supports to be able to navigate, find those resources if they exist, or be able to provide them, right? So a case manager could connect somebody with Meals on Wheels for meal supports, but you have to have the capacity to be able to do that. And again, some of those extra services that people have access to when they have money to do it makes that a lot easier. Being able to pay for somebody to clean your home might be a luxury. It might not be affordable for somebody on a fixed income or in permanent supportive housing, even though that's really what would help them stay there in that setting. And then again, figuring out what somebody's ability to care for themselves actually is. It is really hard to know, and you can actually not predict who's going to do well when they move into independent housing. Because there are some people that, when taken from the unsheltered or unhoused environment and put into housing, regain and rebuild those skills and do really, really well. And there are some folks that continue to have challenges with that and need more support to be able to do that. So figuring that out is really hard. You can't see how somebody's going to take care of themselves or take care of an apartment necessarily until they're there. And so then you're stuck kind of figuring it out if that actually is not the case, if they're really struggling. And going back again to having those resources available to be able to provide that support. Sometimes, again, it's just a couple of supports and sessions around skill building. I worked with a lot of folks when they moved into housing, getting their bathroom set up in an accessible way, helping them practice use that equipment, and then they were fine. But if I was not available as a resource to them, they may not have been able to figure it out. They might have had falls, they might have stopped showering, and that's when we see a lot of challenges. So again, just thinking about that like capacity piece of it, right? Like determining what capacity and decision making people have. This is a quote from a physician from Thomas Jefferson University. There was some Project Home. She says, I have such a clear picture of a number of folks over the years who want to retain their independence and agency. That was their number one goal. Even if that means for them accepting significant risks of accidental death or related illness or injury, the idea of agency and feeling respected as a person seemed to trump everything. If you're 55 and 60 and you have been homeless for 20, 30 years, you have developed so many survival skills. But it might seem to staff that you possibly can't live independently. I think we really need to parse that out and not just go to the idea that the person is not safe. Instead, we need to try to see what the trade-offs are, think carefully about how we can support people either aging in place or letting them do what they want to do and live the way they want to live their lives. It's important that we learn that and get to know that person really well to be able to parse that out. So again, I don't offer you today clear solutions around doing that. Just noticing that's sort of, especially with older adults, one of the layers of extra challenge is really balancing that dynamic. Again, going back to that balance scale from the beginning of facilitating and respecting the person's independence and autonomy and noting when the trade-off there might be safety. I spoke about this a little bit, but we certainly know that there's a lot of challenges in getting folks skilled nursing and long-term care when they need it, whether there's a diagnosis of dementia or functional impairment, that there's discrimination to accessing these facilities based on the person's race, their housing status, their behavioral health history, their insurance coverage. Again, if you're on Medicaid, it's harder to get a spot in some of these long-term care facilities. It makes it hard for our population to access these services when they need it. Once folks are in those settings, again, it can be more challenging for people to want to stay there if they're not trauma informed, if they're not harm reductive. People don't want to give up smoking, right? Sometimes these facilities won't even let folks go outside to take a smoke break, and that enough is to keep somebody from wanting to go into that setting. Again, they may not be providing adequate behavioral health within their facility, and that can make it hard to keep people there once we get them. Again, challenges in accessing housing. Again, I've woven a lot of this into this conversation today, but we know that there's barriers in our housing prioritization process. A lot of communities are shifting to be able to prioritize folks who are medically frail, right, and kind of bump them up to the top of the list. But what the challenges we see in that is in that balance of, well, if this person has medical fragility or a lot of needs, how do we support them safely? So people may qualify for the top of those lists, but then service providers might be concerned about how do we make sure that transition is safe for that building, for that individual. And again, if we're thinking about our housing systems, senior housing buildings, not permanent supportive housing, may have more rules or may have more prohibitions around smoking or drinking or things on premises that are going to be harder for people to manage, especially if they've been doing that a long time. I like this visual, but I have spoken on this visual a few times, right? These are the things that we need to have in place to be able to support people to transition and maintain their housing, especially as older adults. And if these are not in place, this is going to be a little bit more difficult for folks. So um, this is just to illustrate a case story, again, an individual that we talked to as we were building out our resources around this. Just to kind of illustrate how easily this can happen for an older adult to become homeless. He was himself an older adult in his early 60s. He moved cities to be able to provide caregiving for his father, who was at the end of life. Because he was in that caregiver role, he was also working much less hours to be able to support his father. His father passed away. His father was not somebody who had a lot of funds. And so after the estate was settled, there was really no money left and there was no housing left. So this individual hadn't been making a lot of money, didn't have a lot of reserves, didn't really have a lot of finances. The stress of caregiving for his father exacerbated his own healthcare issues, which meant that he couldn't go to work full time. With all of those things together, he experienced homelessness for the first time as an adult at the age of 62. He eventually found his way to a shelter and found a shelter that had some senior specific services. And that was what was really a game changer for him, is that he received support from the shelter focused on the fact that he was a bit of an older adult. And that meant that he had extra support to navigate systems. They did do a cognitive screening with him. His cognition was determined to be fine, but that was good information for him to have. And they supported him in using, he talked a lot about technology, about how hard the technology use was for him and how essential it was that his case managers helped him navigate all of that. Eventually, he was able to qualify for Social Security income and access senior-based housing, first transitional housing, and then older permanent supportive housing. And he was actually able to move into a peer support specialist role at that same shelter to provide supports for older adults. And he noted how much of a difference it made for him to be the same age as some of those peers to navigate some of those barriers and understand that generational gaps around wanting to talk about behavioral health and needing to ask for help and needing help with technology. He feels like he's making a really big difference because he understands that experience exactly. So just to highlight the importance of peer support workers, but for us to be thinking about what that looks like for the older adult population. So again, thinking about you all, there's a lot of recommendations and things that you can do. From a larger system level, something to think about is how you can develop some partnerships within your community. So, how do we not silo ourselves so much, but identifying who your older adult services providers are in your community. Almost every community has an area agency on aging, and that can be a really great place to start. Talking to that agency, figuring out how you can connect services, how you can easily refer folks, and doing some cross training, right? So that their service providers understand how to work with folks who are unhoused and being able to trade those supports and services and maybe even care coordinate together. Similarly, thinking about housing services, if you're in an advocacy role, being able to make sure that housing services are accessible, physically accessible, but also thinking about other supports that might be helpful. Building relationships with people who provide geriatric medical care. Again, there's a lot more complications in providing medications and prescribing, especially for older adults with multiple conditions. So when you have those folks that need that, can you get them into that care? Do they have pro bono spots? Can they accept folks with Medicaid? Like figuring out who those folks are so that you can make that connection when you have an older adult that needs that type of care. Similarly, figuring out who your caregiving and home care agencies are, building a relationship. Sometimes those agencies don't want to come into shelter. And so sometimes it's relationship building so that somebody can access that level of support and services even when they're in shelter or permanent supportive housing buildings, so that those agencies will come in the door and provide the services that they should be providing. And then similarly, again, advanced care planning. Even if you weren't the person doing that, who does that in your community? How can you access that resource and service for the folks that you're working with and that you're serving? Legal supports, planning for end of life. That's just a more prominent conversation. So these slides will be shared out, but these are some resources if you're interested in digging more into it. This is just some more articles around the growth of this population in general, and what some folks are doing from different studies. And then if you want to deep dive even further, although there's a lot of crossover in information, there are some online courses that we helped to develop. There's one through SAMHSA's HHRC, Supporting Older Adults Experiencing Homelessness. That course is geared for any provider across homeless services. So certainly today's training, but if you want to deep dive into an online course about it, you can do that. And then we also have an older adults course for medical respite care. You can also deep dive into the medical and the social needs of that. That may be relevant if you're working in medical respite programs or even just a more intensive shelter program. And those courses are available for free. So with that, I'm going to stop sharing my slides. And we have a few minutes left. I'm happy to answer any questions, or if anybody has additional resources that they have found to be successful with this population, I think that would be helpful to hear about. You all are local to yourselves and your community. Yeah, or any other thoughts or reflections. Open to it.
If you want to raise your hand, I'll unmute you, or you can type it in the chat.
It was a lot of information
It was
to
a lot. It was really good. It resonated with me. My mother um, lived with us the past 2 years, and last month we had to transition her to long-term care. So even though homelessness was not a factor with her, all of the things that you talked about um, are just, unique to people who are aging.
Yeah, and those transitions can be just so challenging, right? Like if your loss of independence is really hard for a lot of folks, transitioning to environments, even when they're more supportive, is
Mhm,
still hard, right? Transitions are just hard in general. My grandma moved into assisted living. It was the right choice, and it
mhm.
still was hard. And we still had to address the behavioral health symptoms. She was feeling more depressed and anxious around that. And you just, you have to be prepared for that with this population, because all of that is kind of going on simultaneously, even when it's the right
Mhm.
thing to do.
Right, yeah. When you were talking about losing the car and the loss of independence, I don't think my mother will ever forgive me for taking her car away from her. Even though it kept her safe, it kept other people safe. And she needed to be able to sell the car and use the money for her care. That was one of the hardest things that we've had to go through with her. And, we're family. I can't imagine, if you're a case manager trying to help somebody deal with that, um, to make that decision. Okay, we've got somebody in the chat. Okay,
And
in child welfare, making sure we have the right resources in rural areas for families that are experiencing homelessness seems to be a barrier. How to get in front of it before families on the cusp of losing housing is so important.
yeah, and that's really relevant, I think, across family systems and then older adults as well, because I think families and older adults, we sort of see that shared experience of folks are sort of living precariously. And that intervention piece, if we can identify who's at risk, can make such a big difference. Even if eventually for an older adult, that person is transitioning from independent housing to a different housing environment, we would rather them go from their own home to assisted living than from their own home to homelessness to assisted living,
Mhm.
right? And if we can catch what's happening, whether it's cognitive issues, whether it's financial issues that are preventing that, and getting services, that can make a huge difference, because sometimes there are things available that can help somebody, but it is more challenging in those rural environments. There
Mhm.
may just not be as much there. The transportation thing is a huge issue in rural environments, right? Where there's not public transportation necessarily. And that's why it's harder for folks to want to give up driving, because if they give up driving, they really can't leave their houses, and then they're isolated, and then, it sort of snowballs. And so figuring out what exists, and even rural communities are covered by area agencies on aging, and they might have some resources that folks don't even know about that can be really helpful there. And some of that prevention piece for sure. Great point. Thank you. And I think also the families too, right? Of when you have folks, I've worked with several individuals that have families who are really, really well involved, but because of the limitations around housing resources, cannot be that support for each other that they would like. There was an individual that I worked with who had a brain injury and had been incarcerated, who was living unsheltered, even though his mom had housing and his mom needed in-home support. Like they were this great support for each other. Because it was senior housing, she was not allowed to have anybody there for more than 2 weeks
Right,
at a time. And so he would go there and stay and shower, but would have to leave and but still did tons of stuff. And I was like, what if we allow them to live together, right? Then we're resolving homelessness. There's combined
right,
income for these folks, and he can do the things that she can't. And, it's just some of these structures we're not very innovative in thinking about that prevent people from being able to support each other, even when that's there.
all right. Other comments or questions before we wrap things up? Okay, we'll make sure that everybody gets a copy of the slides. And don't forget to fill out the survey that will pop up shortly after you log out of the training. And I thank everybody for your time today. Caitlin, this was excellent information. Thank you so much. You've given us a lot to think about, a lot to act on, a lot of good tips. So I really appreciate your time today and your wealth of knowledge. And we know that if we have questions for follow up,
Where to
how to
find
get
it?
that to you. Okay.
Yes.
All
Yeah.
right.
Thank you so much for having me. Appreciate it.
Okay. All right. Thanks everybody for coming and everybody have a great day.